A very good morning to all of you. Very good morning. So I think previously we stopped at GQ type of receptors, right? GQ, right? We will write in another way. So it is GQ type of receptors. So how does a GQ type of receptors act? What they do is they stimulate phospholipase C. You just remember this. Mechanisms. It's very much important. You will be getting in INICET. This phospholipase C increases phosphoinositol pyrophosphate, phosphoinositol phosphate P2. This interval PIP2 increases inositol phosphate 3. This in turn increase calcium ions. So increased calcium levels. So this increases calcium levels. So what this increased calcium levels does? This increased calcium levels, they just they do smooth muscle contraction. Smooth muscle contraction occurs. So what happens is when these GQ receptors are stimulated, it leads to smooth muscle contraction. So examples, if you get to example, if it is something like alpha 1 receptors, it's a type of GQ receptor. Next comes angiotensin receptors. Angiotensin receptor is a GQ type of receptors. Then oxytocin receptors. Oxytocin is a GQ receptor example. And M1 and M3. M1, M3 means muscarinic receptors. There are actually three types of muscarinic. M1, M2, M3, and nicotinic is two types. Nicotinic NN and NM. That is nicotinic and muscular. Right? NN and NM. Next, another type of G protein is GI or GO. What happens is they decrease cyclic AMP. This leads to decreased in calcium levels. This leads to relaxation. So activation of GI or GO receptors causes relaxation of the muscle. Activation of GI or GO causes relaxation of the muscle. So can you give me one example is M2 receptors present on the heart. M2 receptors on heart. What happens is if the M2 receptors are activated, it decreases the contractility activity of the heart. Now one more type is G12 or G13. So what these receptors do is they simply stimulate Rho kinase. The examples of Rho kinase inhibitors are very important. Examples of Rho kinase blockers. What are the examples of Rho kinase blockers? First one is fasudil. It is a potent vasodilator in stable angina. Now one more Rho kinase blocker is netarsudil. This is also very important. Its mechanism of action is a potential NEET PG question. It is used in glaucoma. Netarsudil is used in glaucoma, which is a Rho kinase blocker. Now belumosudil. This is one more Rho kinase blocker. It is called as belumosudil. What is belumosudil do? It is used in graft versus host reaction. That's it. Now the next question is, next topic we will be discussing about trials. What is the trials? Trials are the things which we do generally for the testing of the drug. What we do is the drug goes for nearly four trials, something like 4, some do 5 trials, 5 phases, 3 phases, 4 phases. So what are actually these phases, right? So actually what are these phases and what are the features they have, right? Now first one is phase 1 trial. What we do in phase 1 trial is we check the pharmacokinetics, pharmacodynamics and toxicity and safety. These 4 features, pharmacokinetics, pharmacodynamics, toxicity and safety of the drug, are studied in the phase 1 trial. But in all of this, what is the most important? Maximum tolerable dose of the drug is particularly denoted in the phase 1 trial. Phase 1 trial mainly gives information regarding the maximum tolerable dose. And one more thing is, in how many members it is done? It is done in 20 to 100 members, which are healthy volunteers, normal healthy volunteers? It's a very important question. It's a normal healthy volunteers. It's done in 1 to 2 years, and it's a open label trial. Remember this, it is a MCQ question in Inicet. It's an MCQ question in Inicet. It's an open label trial. I'm just marking it with the red color. You just note it down. It's a open label trial. Remember. Now, if you come to phase 2 trial, phase 2 trial mainly phase 2 trial we define the efficacy. Efficacy is determined. This is a very important MCQ. Efficacy is determined in phase 2 trial, and it's also denoted as, this phase is denoted as therapeutic exploratory trial, and it determines the efficacy, dose range, safety, but main point is it determines the efficacy. It is done in 100 to 500 patients, and it is a randomized control trial. And here the most important point is blinding is done. Blinding is done in phase 2 trial, while phase 1 trial is a open trial, phase 2 trial is a blinding is done. Now phase 3 what you do is therapeutic confirmatory trial. Therapeutic confirmatory trial is phase 3 trial. Therapeutic confirmatory trial, and what we see is we confirm the efficacy. Efficacy is determined in phase 2, but efficacy is confirmed in phase 3. Efficacy, right? Now, what are the other things? It's a multi-site trial. You conduct this trial at different places. It's a multi-site trial. Next is, it is done in 500 to 3000 patients. It's a unicentric trial done for 3 to 5 years. It's a randomized control trial, and here also blinding is done. And main important point of phase 3 is drug is approved by CDSCO and or FDA and marketed. So drug marketing is started in, and drug marketing is done in phase 3 trial. Drug is approved in phase 3 trial. It is approved by CDSO or FDA, Federal Drug Administration. Now phase 4. Now what about phase 4? When you come to phase 4 is a post-marketing surveillance is done. Post-marketing surveillance is done, right? And adverse reaction, that is long-term as well as rare adverse reaction, are defined or studied in phase 4. In phase 4 trial, what we see is adverse reactions, that is a long-term and rare adverse reactions are studied, and it is a post-marketing surveillance trial. The post-marketing, after the marketing is done, the surveillance of the drug is being conducted in phase 4 trial, and you will conduct this trial in many thousands of people, no specific duration, and it is a open label trial. Now you have another 2 more trials, another 2 more phases, that is phase 5, which is also called pharmacoepidemiology. It's not a phase of trial, but it's called phase 5 or pharmacoepidemiology, and there is one more phase called phase 0. Phase 0 is also called a microdosing trial. And the microdosing is 100 microgram. Okay, and the microdosing is 100 microgram. With this we finish the drug trials. Now we will discuss something about adverse reactions, right? We will discuss something about adverse reaction. So what are different adverse reactions? See, there are actually different types of adverse reaction. For example, there is something called augmented adverse reaction, means the mechanism of the action of drug itself, it exhibits some adverse reactions. For example, antihypertensive drugs causing hypotension. Actually, the action of the drug is to decrease the blood pressure, but it's a continuous or abnormal decreasing of this blood pressure leads to hypotension. So the normal action of the drug itself produces the abnormal side effects or adverse reaction, that is hypotension here. Now another one is bizarre. What is meant by bizarre adverse reaction? Bizarre adverse reaction means drugs causing hypersensitivity. If the drug causes hypersensitivity, then that type of adverse reaction is called as bizarre adverse reaction. Now another thing is chronic. What is chronic? What is an example for chronic? Steroids causing HPA suppression, hypothalamo pituitary axis suppression. That is also a type of adverse reaction. But this steroid thing is, remember, it is the main important point. This chronic adverse reaction is dose as well as duration dependent. This chronic type of adverse reaction is dose as well as duration dependent. Remember this. Now one more type of adverse reaction is delayed means you get or observe this adverse reaction after a long period of time. Delayed, generally what is the example for delayed? Drugs causing teratogenicity. It's a delayed type of adverse reaction. Now one more type is, just wait a minute. Now one more type of adverse reaction is end of use, or also called end of use or withdrawal. Generally this type of adverse reaction, example is clonidine withdrawal hypertension. The most common side effect of clonidine is clonidine withdrawal hypertension. It is an example of end of use or withdrawal adverse effect. Now one more type of adverse effect is, I will write it down here. It is failure of the drug. For example, where we can see this failure of drug, enzyme inducers causing OCP failure. Can you tell me one example for it? Anyone? Rifampicin causes OCP failure. Rifampicin causes OCP failure. Okay, so it is an example of failure of drug adverse reaction. Rifampicin causes OCP failures because rifampicin is a enzyme inducer. What does the enzyme do? This enzyme metabolizes this drug. So if the enzyme is induced very much, then obviously this enzyme activity increases and it metabolizes the drug. This drug fastly, this leading to the failure of this drug. So enzyme inducers cause failure, drug failure. Okay, now next going to the other topic, that is pharmacovigilance. I will just give it in a cut short manner. What are the main statements that you should learn in a pharmacovigilance? ADR reporting software is there, means adverse reaction reporting software is there. What is the name of that software? That is called VGFlow. Now National Coordination Center is present in IPC Ghaziabad, which forms the conclusive report. This one forms the conclusive report. See, every statement I just speak here, you just remember those statements. Why? Because they can be the potential MCQs. Now CDSCO Delhi, I just want to say one thing regarding CDSO approves the drug in which phase of the trial? Phase 3. Remember this, phase 3 trial of the drug in which CDSO approves the drug for marketing. CDSO or FDA, it bans the drug based on the report. CDSO Delhi, what does it do? It bans the drug based on the report, right? Based on the report that has been generated, based on the report in which the adverse reactions of the drug are given place. Now International Pharmacovigilance Center is present where? At Uppsala, Sweden. International Pharmacovigilance Data Center is present in Uppsala, Sweden. Okay, next, therapeutic drug monitoring. We will discuss something about therapeutic drug monitoring. What is meant by therapeutic drug monitoring? So the main principle of this drug is the plasma concentration of a drug should have a good correlation with the effects and side effects. For example, if I give you a drug of 1 gram, it will be working as a therapeutic dose, but if I give you a dose of 4 gram, it starts the side effects. If I give you a dose of 6 grams, it obviously land up with some sort of serious side effects. If I give you a 9 gram, then it makes you completely an organ failure may occur, but if I give you 12 gram of the drug, it will become fatal. So what I want to explain here is the plasma concentration of the drug should correlate with the side effects. So it should be clear that what sort of dose of drug causes which action. So it should be very much clear. It should be pinpoint perfectly clear to the practitioner. So if for 1 gram what will occur, for 4 gram what will occur, for 6 gram. So a therapeutic drug monitoring in which the dose of drug, the plasma concentration of a drug should have a good relation with the side effects or effects that it causes. So that is meant by therapeutic drug monitoring. So I think we heard about therapeutic index, right? What is the formula for therapeutic index? Yesterday we studied, that is LD by what? Anyone? What is the formula for therapeutic index? I think yesterday we read it. It is therapeutic dose by ED dose, therapeutic dose by ED50, TD50 by ED50. In case of animals, it is LD50 by ED50. Okay, so therapeutic drug monitoring indications, where we will indicate therapeutic drug monitoring indications, therapeutic drug monitoring indications, where we will indicate clinical effect of a drug can't be easily quantified. The indications where therapeutic drug monitoring is important is, one of the indication is where clinical effect of a drug can't be quantified. For example, you take anti-epileptics. If you give 2 grams of anti-epileptics, what will happen? If you give 4 grams of anti-epileptics, what will happen? If you give 6 grams of so-called anti-epileptic drug, what will happen? So regarding anti-epileptics, you can't design the story like this in a particular protocol, because we can't efficiently analyze what will happen when given with 2 gram, 4 gram, 6 gram. We may give it a vague explanation, but we can't give it as pinpoint perfect as like that, right? If can be quantified, TDM not done, right? If can be quantitative, for example, if we can know what will happen for 2 grams, what will happen if 4 grams given, what will happen if 9 grams given, then TDM cannot be done, TDM not done, TDM need not be done, because we know what will happen if 2 grams given, if 4 grams given, if 9 grams given. Then obviously, for example, if the side effects started at 9 grams, obviously we will stop the treatment up to 4 grams only. So we will give the patient only up to 4 grams. We will not go beyond that. So that is the thing. TDM is where TDM is important. TDM is indicated mainly where the clinical effect of a drug can't be easily quantified. Example, anti-epileptics. If it can be quantified, then TDM not done. TDM need not be done. For example, you take beta blockers. Beta blockers, if you give 20 mg, you know what will happen. If you give 40 mg, you know what will happen. You know what is the fatal dose also, as pinpoint perfectly. So TDM is not done in beta blockers, but in case of sodium valproate, which is an anti-epileptic, in case of sodium valproate, which is a anti-epileptic, you should do the therapeutic drug dose monitoring. So it is as simple as like that. Okay. Now we should know the some of the drugs with low therapeutic index, some of the drugs example with low therapeutic index, right? So some drugs I will write with I will write here with low TDI. You can just simply remember it. It's aminoglycosides, it's lithium, theophylline, drug digoxin, next cyclosporin, next tacrolimus, tricyclic antidepressants. A low, I just give it a mnemonic, a low, we just wait. A low therapeutic drug causes toxicity, right? A for aminoglycosides, L for lithium, T for theophylline, D for digoxin, C for cyclosporin, and T for tacrolimus, tricyclic antidepressant. What is the mnemonic? A low therapeutic drug causes toxicity. Okay, now drugs with variable metabolism. See, there are some drugs, they show different types of metabolism, different metabological systems. Drugs with variable metabolism, example, these are the drugs which are metabolized, by acetylation. They have variable metabolism, right? So they have variable metabolism. Now I will just give you some important drugs with their therapeutic dose and their toxic levels, toxicity doses, right? I will just give some important drugs. For example, first drug is digoxin. You take digoxin, its therapeutic range is from 0.5 to 0.9 nanograms per ml. It is its therapeutic range. This is the therapeutic range. But if you ask me toxicity range, then it is 2 nanogram, more than 2 nanograms per ml. Then one more important drug is lithium. Lithium therapeutic range is, what is lithium therapeutic range? If it is mania prophylaxis, of mania, then obviously the lithium therapeutic range is 0.6 to 1.0 milliequivalents per liter. If it is mania treatment, then the therapeutic dose of lithium is 1.0 to 1.5 milliequivalents per liter. Okay, but if you ask me the toxicity dose of lithium, then it is more than 1.5 milliequivalents per liter. Guys, this every statement is very important. But at what dose dialysis might be needed in case of lithium toxicity? Then it is more than 4 milliequivalents per liter. If the dose of the drug causes more than 4 milliequivalents per liter, then obviously you need dialysis for sure. Now we will talk about one more drug with low therapeutic index, that is theophylline. It is very important drug and a potential drug for getting MCQs in Neet, PG or INSCT. So what is the therapeutic range of theophylline? It's 5 to 15 milligrams per liter. Now if you ask the toxicity dose or toxicity levels of theophylline, at what dose theophylline become toxic, causes toxicity, is 15 milligrams per liter. Okay, I think you got my point, you got my explanation. I think this is okay up to here. Yes, now I will tell you some important points regarding hemolysis, drugs causing hemolysis in G6PD deficiency. This is very important. You won't get a direct question, but you will get a indirect question in the form of 24-year-old boy came with a complaint of so and so, he presents with the symptoms so and so. After giving a drug for a particular condition, the boy presented with so and so complications. So what is your most probable diagnosis? Then obviously, or what is true regarding the condition of the boy in the above given options? Then obviously you will be having an option like the drug caused hemolysis due to G6PD deficiency. You will be having one of the options. So you will get a indirect question in the form of a case. So you just remember these things. What are the drugs which cause hemolysis in G6PD deficiency? Just remember the mnemonic is Dr. Manis. It's Dr. Manis. Doctor, D for dapsone, M for methylene blue, A for antimalarial, N for nalidixic acid, and nitrofurantoin. This is important. Remember, nitrofurantoin causes hemolysis in G6PD deficiency individuals, right? And I for isoniazid. Isoniazid is also important, and mostly you will get questions on isoniazid only. Okay, mostly you will get questions on isoniazid. Sorry. And as for sulfonamide. And as for sulfonamide, right? So these are the drugs which causes hemolysis in G6PD deficiency. Now drugs which are metabolized by acetylation. You may ask me, sir, why this is needed? But this is very much needed. The drugs metabolized by acetylation. Drugs which are metabolized by acetylation. Just simply remember the mnemonic hips, what? Hips dance. H for hydralazine, I for isoniazid, P for procainamide, S for sulfonamide, and dance, D for dapsone. Remember, dapsone. So drugs which are metabolized by acetylation, you can remember with the mnemonic hips D. H for hydralazine, I for isoniazid, P for procainamide, S for sulfonamide, and D for, that is dance for dapsone. Now all these four drugs they causes side effect, that is SLE. This is an MCQ. These four drugs causes SLE, right? These four drugs side effect is SLE. What are those four drugs? Hydralazine, isoniazid, procainamide, and sulfonamide. You got it? So sulfonamide is a drug which is metabolized by acetylation, as well as sulfonamide causes hemolysis in G6PD deficiency individuals. So we will come to the one more topic, that is pregnancy drug categories. So in pregnancy, if you want to use any drug, the category of the drug regarding the usage in pregnancy is being done. So there are actually four categories. Remember, there are actually four categories: category A, category B, category C, category D, and category X. Now what is category A? Category A, category B, category C, they are completely safe in pregnancy. Guys, remember this point. It is very, very important. You will be getting a potential INSCT question. Now what about category D? Category D is something used in pregnancy, but the benefits are greater than risk, might be acceptable. If the benefits outweigh the risks, then it can be used in pregnancy. But what is category X? It is absolutely contraindicated. Category X drugs are absolutely contraindicated in pregnancy, because what happens? They cause serious issues, serious problems, serious complications that you can't even imagine. So everything will be problem, right? For example, if you ask me one example for category X drug in pregnancy, it is absolutely thalidomide. It's absolutely thalidomide. Why? Thalidomide causes what? Very important image based question, phocomelia. Thalidomide causes phocomelia. Remember. Now there is one more thing. Category 4 and category 5 are unsafe in pregnancy. Category 4 and category 5. What is this 4 and 5? That is category D and category X. These two are unsafe in pregnancy. They are completely unsafe in pregnancy. So all of the things are safe in pregnancy. All of the below category drugs are safe in pregnancy, except, and you will give category A, category B, category C, category D. Answer is category D. Category D and category X are completely unsafe in pregnancy. But if the benefit outweighs the risk, you can accept category D drug to give to your patient, but category X drug is completely contraindicated. Now we will move on to the next topic, that is, what is that? We will move on to the next topic, that is system, autonomic system, the nervous, autonomic system, cholinergic system and adrenergic system. What we will do in this session, we will just discuss each and every system parallelly. For example, we will take cholinergic, we will take anticholinergic, we will take adrenergic, and we will take anti-adrenergic. Not a problem. Okay. Now I just want to say one thing, just please stick on to the class, don't get deviated, just stick to the class. We'll just take it as fast as we can. Okay. Now here we'll write the type of nervous system. Guys, this is very important topic, please concentrate. It is a sure shot question in the examination. You will get 2 MCQs from this thing, right? Type of nervous system, then receptors, then neurotransmitters, then rate limiting step, this is very important, and finally drugs. Now type of nervous system. Now parasympathetic. What is the outflow of neurons? What is the outflow of nerves? It is craniosacral. From which nerves you will be getting? 3, 7, 9, 10. 3, 7, 9, 10. Next S2 to S4. These are very, very important statements. Just remember. So what is the outflow of parasympathetic? Craniosacral of 3, 7, 9, 10 and sacral S2, S3, S4. Now what are the types of receptors in parasympathetic? You have 2 types of receptors. One is muscarinic and another one is nicotinic. So these are the 2 types of receptors. What is the example here? Muscarinic, if you take, which type of receptors? They are GPCR, gene protein coupled receptors. Nicotinic is ionic receptors. What is the neurotransmitter in complete parasympathetic system? It is acetylcholine. Now what is the rate limiting step in parasympathetic? Rate limiting step in parasympathetic is choline reuptake. That is the rate limiting step. Now some of the drugs regarding parasympathetic. What are some of the drugs? Right, just we will talk about. Now what are the drugs? Aminoglycosides. They block presynaptic voltage gated channels. What happens is these drugs in which aminoglycoside they block presynaptic voltage gated channels. Now, if you ask me what about botulinum toxin, the botulinum toxin blocks the release of acetylcholine. Botulinum toxin blocks the release of acetylcholine. Botulinum toxin acts the release of acetylcholine. Okay, blocks the release of acetylcholine vesicles. Right, acetylcholine vesicles. Now, if you ask me one more thing, this is all about parasympathetic. Now we will discuss about sympathetic. Now we will discuss about sympathetic. I will just kept a break there. We will discuss about sympathetic. What is the outflow here? Dorso-lumbar outflow. Dorso-lumbar outflow. Dorso-lumbar outflow means T1 to T1 to L2. T1 to L2 or L3. T1 to L2 or L3. And what are the types of receptors in sympathetic? What are the types of receptors in sympathetic? It's alpha 1, alpha 2, alpha 3, and beta 1 and beta 2. Alpha 1, alpha 2, alpha 1, alpha 2, next beta 1, beta 2, beta 3. Beta 1, beta 2, beta 3.